And now it is my distinct honor to introduce our first speaker, President of ALD Connect. Let's give a warm welcome to Dr. Florian Eichler.
Great. Wonderful, and nice to see this full room, and I'm always delighted to see this extended family and all the people that have come together to help make lives of patients affected by ALD better. And many new faces, many old faces, and people who are coming from all over the country, and companies coming all the way from Japan, and patients from Korea. So I'm really delighted to have this larger community here. So what I thought I would do is just set the stage here a little bit, because it's often a mixed audience, and there are experts among you, but there are also people who are here for the first time who might not understand ALD or know about some of the details of the genetics or the new therapies. So I entitled this Building the Future for ALD, Paradigm Shifts in Therapeutic Opportunities, and see it a little bit as a journey through the last 12 years of what we've done since we've been in ALD Connect. So just briefly here, some disclosures, various trials I've been part of, and consulting to various companies. So let me start off with where really this journey started for me, which was 20 years ago with Hugo Moser, at a time when really what we knew about adrenal leukodystrophy was largely based on probably the most horrible face of this disorder, a brain disease that really left many of our loved ones disabled and without the ability to communicate, and with brain disease that was very hard to treat because it was far too advanced. And my mentor, Hugo Moser, struggled with this greatly as he was recognizing that he had to do this with families, with patients. They were the power that would help transform this. It was actually here in Boston that for the first time 40 years ago, this disorder that was originally called Schilder's disease was then recognized to be an inherited disorder. So what I will show you in the next 15, 20 minutes is how we've really shifted the paradigm from this very fatal, disempowering situation to genetic disease, now also biochemically defined, and now with therapeutic options, and recognizing that it's much more of a spectrum that goes beyond the brain alone, involves the spinal cord, peripheral nerve. It goes beyond the boys and the men alone to also involve women. And understanding this spectrum makes all the difference in us understanding how to treat this. So the spectrum of disease beyond a male brain disease. So today we know, as opposed to 40 years ago when there was the Schilder's disease described, that this is a genetic disease. And the genetic disease is really based on a mutation in a gene called ABCD1 that encodes a transporter on the peroxisome that you see here on the left. And this peroxisome imports very long-chain fatty acids for degradation. And hence, if you don't have these very long chain, this transporter being functional, you have accumulation of very long chain fatty acids. And another piece of history here was just about 20 minutes away from here in Waltham at the Shriver Center, where a technician left a gas chromatograph on overnight, and by pure accident discovered the next morning these new lipid peaks that then became known as the very long-chain fatty acids, showing that serendipity really was so key to discovery of the biochemical basis of this disorder. Without that, we wouldn't have known about the lipid component. We wouldn't have newborn screening. We wouldn't have many other things occur. So beyond male brain disease alone, we know now there's adrenal dysfunction. That's part of this. We also know that the spinal cord in the axonal degeneration component is a huge part of this disease. And not only are men affected, it's also women that are very severely affected with their myelopathy, albeit about 10 years later than the men. Why does this matter? It matters because this spectrum of disease beyond the brain alone and the involvement of spinal cord, the involvement of the adrenal gland, and also in the myelopathy in women is treated differently than the brain disease. The brain disease you can treat with a bone marrow transplantation, with ex vivo gene therapy. You will not want to do that for the myelopathy, for the spinal cord symptoms, and you have replacement of hormones for the adrenal insufficiency. It also tells us how we need to monitor for this disease and what compartments to perform regular MRIs on, how to do blood work, and all of that has been a huge boost to the field and to families that are seeking careful monitoring for their children. So the first paradigm I would emphasize this is treatability due to our understanding of the spectrum, but also recognition that early detection is the key to successful treatment. If we get to an earlier intervention, it is always more effective than treating at an advanced stage. So we've gone from really an untreatable condition at the time when I was with Hugo Moser at Kennedy Krieger to really a modifiable disorder. Early hematopoietic stem cell transplantation has proved that neurological stabilization is possible. And now, most importantly, we have pre-symptomatic detection by newborn screening that transforms outcomes. So what better way to treat than to detect early before the child is even affected? And that has been a major paradigm shift for our field. So just a word about the impact of bone marrow transplantation. So this was really performed, again, a little by serendipity at a time when we didn't really understand the basis of this disorder to the fullest. But it became quite clear that among many devastating neurologic diseases, adrenal leukodystrophy was one of them that for cerebral ALD was quite effective. And it works because you're taking here bone marrow cells from a donor and you're delivering them to a child affected with this inflammatory brain disease. The bone marrow cells move from myeloid precursors to monocytes, and they move from bone marrow to blood, blood to brain. And we think, at least in part, are effective because they replace microglia. But in many ways, this is still a mystery, and there might be other ways that this is effective. What we do know very well is that the earlier you perform a bone marrow transplantation in cerebral ALD, the more effective it is. So you can see here, sorry, I'm trying to figure out if I can use a pointer here. No, doesn't look like there is, but. Oh, sorry, got it. So you can see here, this is what happens when you treat in an advanced stage of cerebral ALD, when you can improve overall survival, but you have real loss of neurologic function, and sadly, many of these boys lose their ability to walk and talk. But if you treat in an early stage of cerebral ALD, not only do you improve overall survival, but you're able to stabilize neurologic function. And this became an important basis for ex vivo gene therapy. Newborn screening really happened around the same time we started ALD Connect, and we launched first gene therapies, and it was really a perfect concordance of many efforts that brought mutual success about. Newborn screening, thanks to Elisa Seeger, thanks to the patient community, many people depicted here, really have led to a transformative diagnostic wave that has now led to newborn screening across almost all of the US. And just to highlight that the value of measuring lysophosphatidyl-choline and the very long-chain fatty acid component therein may, beyond the diagnosis, also help us to unravel who might be at higher risk for cerebral disease, for adrenal insufficiency than others. And we have frequent discussions about what that means. And Stefan Kemp and the group in Amsterdam are really leading that effort. And so this is, I think, really a huge step forward and something that's going to help us tailor treatments in the future. So gene therapy for males, transforming the prognosis. We have now gone beyond bone marrow transplantation to develop ex vivo lentiviral gene therapy. It restores ABCD1 function, halts demyelination when applied early. Why did we need this beyond the hematopoietic stem cell therapy and bone marrow transplant alone? It helps here avoid engraftment problems and graft versus host disease. It's really expanded options for those that do not have donors available. And we've seen durable benefit observed, but we need to be vigilant as to long-term safety and efficacy, and there's much that we need to still build on. So how is ex vivo lentiviral gene therapy performed? Just briefly, for those who are new to this, once you see a brain disease in a boy with contrast enhancement, we harvest their bone marrow cells after mobilizing them into peripheral blood, take them, select out a component of them called the CD34 positive cells, use a lentiviral vector to deliver a healthy copy of the gene, and then we give these cells back after a brief amount of myeloablation with busulfan and cyclophosphamide, and follow these boys over a 2-year period. And this has been really quite transformative, and we see that we can do this without getting engraftment problems, without having graft versus host disease, and these boys stabilize over time. Just to briefly highlight some of the long-term survival and major functional disability-free survival that was published last year. At the same time, we know there are also still ongoing concerns over insertional mutagenesis and hematologic malignancies that we are actively working to address. So the second paradigm shift here to mention is expanding beyond the brain alone. We now know that beyond cerebral ALD, there are many other components to this disorder. One of the most important ones being the spinal cord disease. AMN and progressive spinal cord disease remain a major unmet need. We need to focus on how to get durable gene repair into the spinal cord, and there's many active programs trying to also achieve metabolic correction. Just to highlight for those who are new here to this field, what does the spinal cord disease mean? There are 2 major tracts that are affected. One that brings signals from the brain down through the spinal cord all the way to the muscles. This is following what we call the corticospinal tracts, and the other being a tract coming from the sensory neurons up into the back posterior columns, dorsal columns of the spinal cord, up into the brain, bringing sensory information about our joint position, about our sensation up into the brain. So my mentor at Kennedy Krieger, he used to wave his large arms to denote the longest tracts here in the nervous system were affected, pointing to the fact that that was probably a vulnerability here in this disease. So how do we achieve gene correction to the spinal cord? We've spent the last decade really working in the lab on using an adeno-associated virus to deliver a healthy copy of ABCD1 to the spinal cord, similar to what happens in children with spinal muscular atrophy. And to make a long story short, we've been able to go from in vitro culture work to mouse work in various models, delivering here with an osmotic pump into the spinal cord and achieving not only a metabolic correction, but also behavioral improvement in these models. And this has now then resulted in a clinical trial with recombinant AAV9 vector delivering into the intrathecal space here of patients run here by Larry Hayward at UMass, as well as Mark Engelen in Amsterdam. And this is a slow infusion that occurs over several hours and has been shown to be well tolerated. We've treated 4 patients in the US and 4 patients in Europe. All participants experienced at least one emergent adverse event. Most of these were headaches and back pain after the lumbar puncture, most non-serious. We did not see significant laboratory abnormalities. Vector DNA shedding peaked early and cleared within 30 to 90 days. We did see evidence of cerebral ALD in 2 participants, one in the low dose. He turned out to have a lesion that had just started before we had done the infusion. When he unfortunately had such fulminant AMN that he died 6 months later, and death was deemed unrelated to study treatment. And then we had one patient at high dose who had some enhancement in the spinal cord, which has improved. So a road general of safety, but still a lot of things to learn. And the duration of this trial really has not been long enough for us to draw conclusions on efficacy, but we think here's important proof of concept that yes, we can target the spinal cord, and yes, we can deliver ABCD1 to the compartments that need it. So an important further paradigm shift is to recognize that women with ALD that were for decades called carriers are really affected patients. And to recognize the true disease burden in women, I think, has been a major shift in our field over the past decade. We now know that up to 80% of them develop spinal cord symptoms and neuropathy. And you can see here in our cohort that was first published about 5 to 10 years ago of 127 women, that the burden of disease really increases with age and has a very similar pathophysiology to AMN. It's one of axonal degeneration, oxidative stress, and inflammation. I often get questions, are women really affected in the same way as men? And I thought really pictures and videos speak more than words. I want to emphasize how much women who have high, very long-chain fatty acids and myelopathy are suffering here with gait difficulty, spasticity, balance problems. And this is really something that is right now completely unaddressed, and we don't even have good model systems or trials that are reaching out to help these women. So females have a similar disease burden to males, albeit later in onset, and you can sort of see here time to myelopathy symptoms in females that is about 10 years behind that in men. And these myelopathy symptoms really have a whole slew of consequences. They lead to injuries and comorbidities among women. So beyond the neurologic dysfunction, there's then secondary complications of falling, of injuries, of fractures, often the urinary symptoms, the neurologic symptoms contribute to poor sleep. There's insomnia, there's depression and anxiety that is exacerbating sleep, and the poor sleep exacerbating the mood symptoms. So all of those things really exacerbate symptoms day to day in women. I think I'm hoping to convince you here in this brief talk that there's really convergence of biology across the sexes. There's a shared mechanisms, shared targets, there are common molecular drivers. In both men and women, there's lipid dysregulation, mitochondrial dysfunction, neuroinflammation, opens a path towards unified therapeutic strategies rather than sex-segregated ones. For many decades, we've thought about this disease as so separate in men and women that we've not included women in trials, when I see the pathology being so prominent that there's really no reason not to. And that should be sort of a call to arms for us. just to drive this point home, I'm going to briefly present a woman with cerebral ALD who presented, 27-year-old woman with myelopathy and adrenal insufficiency, bladder and bowel incontinence, motor difficulties. So for all we could tell, this was AMN, but she had highly elevated very long-chain fatty acid levels, and X inactivation studies showed a skewed ratio where she had 100 to 0 with really complete skewing here towards the mutant X. At 36 years, she was wheelchair-bound. Now, word-finding difficulties, blurry vision. You could see on her MRI she had a lot of cerebellar involvement. Her brainstem was involved. She was starting to have inflammation in the corpus callosum as well. At 39 years, she had double vision, paratonia, dysphagia, and speech difficulties, and she died after an aspiration pneumonia. This is really second to none of what happens in boys and men. And just to emphasize that here, the levels of the very long-chain fatty acids and the skewing make all the difference. So it's not about sex, it's about biology, okay? And in this case, the biology is one of complete skewing that the ABCD1 protein is drastically lowered, and each woman has to be assessed separately for this. Here's a woman who had skewing towards the healthy X, and she had completely normal ABCD1 and normal levels of very long-chain fatty acids. But the woman I presented had almost no ABCD1 and levels of very long-chain fatty acids that were in the male range and in the higher male range, showing how much at risk she was. So we've figured out how to actually create a female ALD mouse model by imitating this X inactivation and the skewing, and we've shown that we can, in brain and spinal cord, by targeting a particular molecular target on the X chromosome, really achieve this complete skewing towards the mutant X with almost no ABCD1 detected in brain and spinal cord, and this correlates with very high, very long-chain fatty acid levels that are very similar to those in men. And we think that this first female ALD mouse mimics the severity I'm seeing in many of the women. So can we target skewed X inactivation therapeutically? And I think the answer is yes. We're doing a lot of work in fibroblasts, and many of the women are generously giving us samples to test not only for the X inactivation status and the very long-chain fatty acids, but also allowing us now to screen drug libraries to find compounds that might reactivate the healthy X, knowing that there are two copies here, and that if we can get the healthy copy back, this would be of therapeutic benefit. So there are shared therapeutic opportunities. There are really reasons to bridge male and female treatment strategies. We need to think comprehensive. We need to think jointly about these. We know that very long-chain fatty acid lowering agents and drugs to improve mitochondrial function show promise across phenotypes, that there is data here on laraglitazone and other studies that have gone all the way from proof of concept into trials, and that really allowed us to open the door to a new area of metabolic correction. And probably in the future, we're going to see combination approaches where gene correction and metabolic correction, neuroprotective therapies come together. And this should really be tailored towards the biology, and the data with the LPCC26 and information such as skewing give us a chance to really precisely stratify and move forward. Do other genes influence how ALD manifests? I think both our neurologic phenotypes as well as the LPCC26 levels are giving us insights that there is not only skewing, but there might be also different genes that are contributing, knowing that the ALD gene is just the one that's important for important degradation. But there are other genes and proteins that are influencing the synthesis or the saturation status of very long-chain fatty acids. And I know in particular ELOVIA1, the enzyme that causes elongation and of very long-chain fatty acids, has drawn a lot of attention. So I think in the next few years we're going to see more work on these various modifier genes and understand how they might be possible targets. But just to point out that even if you have a functional ABCD1 gene, and you overexpress ELOVL1 in a mouse, you can not only bring about elevation in very long-chain fatty acids, but you can also see neurologic symptoms arise in these mice, and they become hypersensitive and start to develop what we call allodynia and pain, very reminiscent of what we see in adults and men and women affected by AMN. So, how do we build an inclusive therapeutic framework for the future? How do we go from newborn to adult and across the sexes? I think we have a real chance to build something across the lifespan, and we have to think in a more integrated way rather than just focusing on individual phenotypes alone. We have to integrate newborn screening, early gene therapy, and adult neuroprotective trials, achieve lifespan-wide management, combining metabolic, endocrine, and neurologic care, knowing that there's a lot of interplay between these various different components. We know that we need to optimize our ex vivo gene therapy and come up with better lentiviral vector design for cerebral ALD. You'll hear this afternoon Dr. David Williams speak about some of the new vector constructs that he's working on, recognizing that we probably used a too strong promoter in the first generation of ex vivo gene therapy, and we now have a chance to improve upon those first vectors and test them and also use a better understanding of insertional mutagenesis to evaluate these moving forward. In the meantime, there's also been a whole wave of new technology in gene editing, and Ben Kleinstever here at MGH has done a lot of work on base editing and also prime editing to allow us for precise editing of ABCD1. Just in a nutshell, what's the difference between gene therapy and gene editing? In gene therapy, you're adding, you're achieving overexpression of the healthy gene, whereas in gene editing, you are trying to preserve the endogenous, the physiologic promoter, and achieve physiologic levels by simply swapping out individual base pairs and achieving a more precise correction of the gene. What is needed therapeutically is still something we need to think about and compare and do assays in culture and in mice in order to figure this out. But it's an exciting time to have these tools at the bench. I want to leave you here on a hopeful note, just to show you that despite some of the difficulties we've had with ex vivo lentiviral gene therapy, there's also much to celebrate. Here's a boy who came to us 8 years of age who had lesions in the brainstem and inflammation and contrast enhancement. And 2 years after therapy, these are completely disappeared. So for all intents and purposes, we've been able to correct the lesions and reverse lesion load, something that we don't see very often. But more importantly, he had myelodysplastic syndrome, and despite having myelodysplastic syndrome and going through a separate transplant, he's really retained his neurologic function so beautifully, and he runs with a stride that I, at my age, can only strive for, and he has beautiful balance and speaks both Spanish and English. So we're very proud of what he's done. So here's the road ahead for XALD therapeutics. Just in brief, we need to have gene therapy success in males. That marks a paradigm shift and needs to be further improved. I think it's given us a proof of concept, and there's still more work ahead, but let us hold on to what we are learning as we move forward. Recognizing and treating females is the next frontier for equitable progress. This is not so much an either-or, but rather we're learning from each other. Everything we're learning in women has consequences for the men and vice versa. And I think there's much to be said about that. So it's been 12 years, and I'm really in awe of all the people who have been able to work with and who've really brought this about. Our first meeting here in Boston, 2013, was with Patrick O'Bourg, who did some of the first seminal work in gene therapy. A shout out to my wife, who came up with the name ALD Connect. So she of course deserves credit for many other things, but that term came from her. I will also say the logo was made by a friend of mine in art school. I studied painting at the Rhode Island School of Design before I went into medicine, and an old friend of mine, he came up with this logo, and so it really takes a village, and I've been very fortunate to have so many partners in this. And a big shout out to Kelly, who is now really the person driving so much progress forward and implementing so much change and helping our organization and operations. But for 10 years, it was really Kathleen O'Sullivan-Fortin who did all the heavy lifting for us, and I couldn't have done anything without her. And so I just want to emphasize how much she also put up with me in those years. So much to be grateful for. Thank you.